on the previous from last week. The basic views, whether it's skull or facial bones, is always going to be a PA Caldwell, a lateral, a Townes, okay? And then an SMV. Those are the basic views. Those are the same basic views that you're going to see also with facial bones. Maybe a couple more, like the parietal Canfield, which is the Reese's view. Then we have the Waters view. So you've already know 4 of these. I'm probably just going to discuss another 2 or 3. The only difference is that if it's Caldwell or a Townes or a lateral, the central ray changes, but the position is the same. Because are we focusing here, are we focusing here, are we focusing here? But the positions are the same. The positions are the same. Am I centering here, 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 or here? It's just the change in level of your central ray. That's the only difference. So it sounds like there's a lot of views, but they're repetitive. Okay? And that should help alleviate some of the stress. Okay? Because there really isn't a lot of views. They're the same views and projections. They're the same. Okay? So if you can get that ingrained in your head, they're the same. What makes a difference is the central ray. Okay? All right. So let's begin. First, let's look at the difference here between PA and Waters. With PA 0 degrees, again we have the ridge filling the supraorbital at the edge of the supraorbital margin, and the petrous portion fills up the orbits. Okay, but if you look over here, if we do a very extended chin extension, it's going to bring the petrous ridges below the maxillary sinuses. And so here we have the Waters. And again, if you just can imagine, because I was asking this with my students in lab, when we were doing the PA, we weren't getting the ridges exactly on 1/3 of the orbits. And I would ask them, I said, well, what do we need to do to correct that? And so do we need an extension or do we need a flexion? And again, if you just hold the petrous ridges like this, okay, they stay at the same level. Okay, so if I want to get them in the lower third, I'd have to do more of a chin depression. Get it? If I want to fill up the orbits, I'm going to do even more of a chin, I said extended, a flexion. Okay, if I want to get them below the maxillary sinuses, it's going to be a neck extension. See that? But they remain in the same level. So that's how you would correct it. So here is an example of what we were just talking about. So in the PA 0 degrees, the petrous ridges, which is right here, fill up, right here, petrous ridges, or the portion is going to fill up your orbits. Okay? With an extension, look what happens. It brings still the same level here, but with a chin extension, it brings it below the maxillary sinuses. Okay? What's MML? Mental medial line referring to what? What's your mental? Chin. The chin. Okay, so here we have the chin to your ear hole perpendicular with the image receptor. Okay? All right. This is referring to, do we choose to do it upright or do we choose to do it supine? Generally, if it's skull, you can do it either way. Okay? But now if we're looking at the facial bones and we're looking at the sinuses and things like that, we would like to do them in an upright position because fluid levels will indicate there may be some injury within the skull that we can't see radiographically. Okay, so sinuses, facial bones, we'd like to do them in an upright position, okay? If they're sedated, if they're traumatic, if they can't move for you, then of course doing it on the table would make a lot more sense, okay? All right, so lateral facial bones. Lateral facial bones. You guys already know this, okay? Mid-sagittal plane. It's going to be what?
Parallel.
Parallel. Interpupillary is going to be?
Perpendicular.
Okay, perpendicular. Okay? What's also saying here is now we also want to use the IOML. The IOML is the imaginary line from underneath your orbit, so this right here underneath the orbit to your AAM. What they're saying there is we want you to adjust the head so that that IOML is perpendicular with the image receptor. We're trying to just get your head straight. When we're doing a lateral, we don't want this or this. It's just, we're just trying to get your head straight. That's what the IOML line is used for, okay? So the IOML perpendicular to the front edge of the image receptor is what it's saying. Okay, so we're just adjusting the tilt of the head. So in your lateral skull, we were 2 inches above the EAM. Here, it's just saying center to the zygoma, your cheekbone. At the level of the EAM. You're at the level of the EAM, just right there. Right at the cheekbone. That's your central ray. Okay. Structures best seen is superimposed facial bones, including the mandible. So how do we find that zygoma midway between the EAM and the outer canthus? Easy enough, right? Oh, it looks like there's motion in here. We have to do this one again. Okay, zygomatic bones are centered in the radiograph for optimal exposure. What's an optimal exposure?
It's the least amount of exposure that gives us the diagnostic
Give me
image.
KB.
75 to 85.
70-ish? Okay, 70-ish. Okay, 70-ish is appropriate. Okay. All right, so, God, there's a lot of these fade-ins here. I got to fix these slides. Okay. So optimal exposure factor between 70 and 80, so 70-ish. No tilt. Again, this is tilt. Okay, a break in the central axis, that's a tilt. We're looking at the orbital roofs, making sure that they're superimposed. No rotation, you should see just one mandible. Okay, greater wing should be superimposed. Okay. Oh, what happened to the skull? We missed the skull.
We need face.
Are we okay?
Yeah.
Okay, because we were doing face. We need face. Yeah, we need face. We are only doing facial bones, so we don't care about the skull. Just like when we did the lateral skull, if we chopped off the mandible, it was okay because we were doing, we're doing cranium, not facial bones. Okay? So if we cut off the cranium, it's okay. Collimate to the area of interest. Again, collimating reduces any radiation exposure. It also gives you a more of a black and white image. All right, here's the waters. Okay? What baseline are we using here for the waters?
MML.
MML. So mental meatal line. So they're going to do a chin extension. Okay, mid-sagittal plane is going to perpendicular. Okay? No rotation. Then MML is going to be perpendicular. Chin extension. Can we also do this AP?
Yes.
Okay. This may be tough to do. Now, if you are bigger chested, if they work out, if they're hyperstenic, it's going to be difficult for them to lay on their belly and yet have their chin touch the image receptor. Okay, this is good for an average sized patient, but it's harder for someone who is hyperstenic. So you may have to use a little bit of some creativity in trying to get that chin extended and trying to maintain a sharp OID. If you can't do that, then you may have to do it on their back. Same thing, you can do it on their back. MML is perpendicular to the image receptor, so you can do it that way too, okay? Central ray is going to match that MML. Central ray is going to exit the acanthion. Where's the acanthion?
Under your
Right there.
nose.
Okay, so this again is where your nose attaches to your face. Okay, so that's the exit. Okay. So when the MML is used, it's going to form a 37 degree angulation between your OML and the image receptor. So this might be even easier to do. It's hard to do it on the table. It's going to be a lot easier to do it standing up. Again, central ray to exit the acanthion. So what do we say? So we want to use good hygiene, right? So the patient's going to be putting their face on this. So we want to clean it before they put their face on there, and then clean it afterwards. So the next patient that uses the board is going to be nice and clean, germ-free. All right, so petrous ridges are going to lie below the maxillary sinuses. Arrows point to the petrous ridges. You have the maxillary sinuses that are free and clear. Okay? This is also good for RO, stands for ruling out. This Waters U is good for ruling out Lefort's or Lefort's and the tripod fracture. It's also good for foreign body to the eyes. Good for localizing foreign body to the eyes. Lefort's basically is a horizontal fracture of the maxilla, and they have different categories. You have 1, 2, and 3. 3 being the worst. But again, it's a horizontal fracture involving the maxilla. So the Waters is good for that. And it's also good for the tripod fracture. What are we telling our patients, by the way, while we're taking these x-rays? Hold your breath?
Yes. No?
Really? Just hold still, don't move. Yeah. You can tell them to hold their breath. I think I mentioned that last week. You can probably tell them to hold their breath, because if they're breathing, you know, their head might move. Your call. Okay? Do as they do. Whatever they're doing out there in the field, there's no wrong on this. Okay? Hold your breath, hold still, or just hold still, don't move. Is appropriate. Okay? All right. Bony nasal septum with no rotation is equidistant on the outer edges. So can you guys see the bony nasal septum? Equidistance on both sides. Okay, you guys already know the PA Caldwell, right? PA Caldwell for the skull. Where was the exit for a PA Caldwell for the skull?
Nasion.
No, for the skull.
Nasion.
Is it the glabella?
No, glabella is for 0 degrees.
Oh,
Glabella
0
would be for
degrees,
0.
okay. All right, thank you.
You're welcome. Anytime.
All right, so it doesn't change here then, right? It's the same. Except we're just collimating to the face. We don't need the entire skull, we're just collimating to the face. You guys already know this, okay? So 15 degrees towards the feet to exit the nasion, right? Which line, baseline are we using here?
OML.
Okay. OML. What is the degree of angulation if they can't tuck in their chin? Instead of using the OML, let's use the IOML now, perpendicular. What is the degree of angulation there? 37 degrees. Okay? So if they can't do that, you can use the infraorbital line. So same applies. You can use the infraorbital line with a 37-degree angulation towards the feet. Now if it's an AP, how many guys shot your skull's AP in your lab? Okay? Okay, so you guys did both. You did PA and you also did AP. Okay?
Just AP.
So if you do an AP, which way is your angulation now? Cephalad. Okay, there was a hands up over there. Gio?
So where exactly is that the beam entering? Is it the anion or where it enters in the back of the head? Like where does the beam enter?
Well, what you're going to do here, I can't answer that. Because remember, you have the different size and shaped head. What we're looking for here is you're looking at the crosshairs. You see where the crosshairs is exiting. So look at the table. Okay, you're not going to see where it's entering, but you can see the crosshair as it hits the table. Have the crosshair at the level of the nasion. So it should exit the nasion. Yeah. Actually, we did that with James. We did that in our lab because we had a hard time finding. I said, you know what? Don't look at where it's entering. Look at where it's exiting. He goes, well, I can't see where it's exiting. I said, open up your collimator. When you open up your collimator, you see the crosshair at the level of the nasion. Okay, make sense?
Yep.
Okay. Good question. Okay.
Huh?
Oh, I thought you had a question.
No.
Any other questions? Okay.
I can come up with some.
I know you. All right. Okay, so what we know already about P.A. Caldwell is that the Petrus Ridge should fill up the lower third of the orbit. Again, you have your same criteria here of Christogaule, equidistance to the outer margins, or the mid-lateral. The middle lateral part of the orbit is also equidistance on both sides to the lateral margins of the skull. Okay. You guys like this?
Love
it's a good
it.
shot, right? It's a good shot. Yeah. Okay. Modified waters. We did a waters. The waters was MML, right? Modified waters is now we're going to use the LML. What's LML?
Lips.
Lips, meatal line. So now, yeah, they're going to be using the lips. So the lips meatal line is going to form a 55-degree angulation with the IR when we're using the OML. But LML is going to be perpendicular. Okay, it's modified. We're not using the chin. So with the modified version of the waters, this is good for demonstrating possible orbital fractures and foreign bodies in the eye. For example, a blowout fracture would be good in using the modified waters. We're able to demonstrate the floors of the orbits a lot better in this particular projection. Okay, so this is a good view for looking at the floor of the orbits. Okay. It actually looks somewhat rotated. You guys agree? Yeah, it's a little bit off. Okay, so Petrus ridges now are going to be projected in the lower half. So here is your maxillary sinus. It's going to be projected in the lower half.
Excuse me.
Bless you.
Thank you.
Lower half. Except here it looks like it's lower third. But it should fill the lower half. Yes.
How does being hit in the eye in this way cause the bones to go, the fracture to go?
Because the muscle itself is attached to the floor, so the lower fracture is actually going to pull and project the floor of it into the maxillary sinuses. So it's all from the tension of the muscles around that area. It'll force it.
Like a rebound?
Like a rebound, if you will. Yeah. 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 The other thing too is the floor of the orbit is a lot thinner than the rest of the eye. So when you're looking at the orbit itself, it's the thinnest part is at the floor, which again it goes to the I can't think about it. I'll get back to you later. It goes to the path of least resistance. The path of least resistance is going to be the thinner floor of the
and the eyeball's
orbit.
pretty tough.
Yes.
Okay.
Yeah. Yes.
So in these different studies, depending what you're focusing on, do you use a collimator like a cylinder, or to get a better shot, or does it really matter?
It doesn't matter, because let me ask you this: how many of your places still have a cylinder cone? You don't. Yeah. The cylinder cone we use almost predominantly for head study, and since the advent of the hard technologies of imaging, they got rid of that because we can get good detail now just simply collimating all four sides. But the whole purpose of this was that it gave us optimal visualization of the study because it was a true beam limiter in absorbing scatter radiation. It was a really true beam limiter. So absorbing scatter radiation and improved contrast, which also improved the resolution of the image. But we don't need that anymore because of our digital imaging. Okay, any questions here? So again, we don't care about the skull. See, the marker is in the skull, but do we care? No? I keep saying skull, the cranium, the entire thing is the skull. So the marker is in the cranium. We're okay with that because we're looking at the facial bone. Okay. All right, look, same views again. Now we're going to look at the nasal bones. Lateral, Waters, Caldwell. See how easy that is? It's just the same views over and over again. So maybe I should stop lecturing.
Stop quizzing us. Stop quizzing us.
Okay, nasal bones. Nasal bones, okay? Thin bone, it's the bridge of your bone, bridge of your nose, okay? Again, same criteria. Mid-sagittal plane, parallel, interpupillary, perpendicular, IOML, perpendicular with the edge of your cassette, okay? Central ray now, so positioning is all the same. Central ray will be now half an inch inferior to the nasion. Half an inch. It didn't say nasal bones, it's inferior to the nasion. So where's your nasion?
Yeah.
It's above your nasal bones. Okay? Right here. So when you actually go half an inch below that, central ray is at the nasal bones. You like the way it's written? It's the same. It's all perspective. Okay. All right. Now, when doing nasal bones, because there's two of them, we generally do them bilaterally. So we'll do a left lateral, and then we'll do a right lateral. Okay? Other key point when you're doing nasal bone, look how small it is. How much collimation do you think I need? Not much at all. Okay? Thin bone. Do I need a lot of KV? So low KV, collimate to the area of interest. And look how close the nasal bone is to the eyes. Okay? So collimate, be nice to your patient. This is all you need. Nasal bone, very thin. All this here, this is just cartilage. Okay? So we do it bilaterally. One left lateral, one right lateral. And this probably doesn't matter anymore. Slow speed screens, we do digital imaging. So what is important though is we're using low kVp. What did it mean by slow speed screens? Is that good or bad? Does it give you better detail or the same detail?
Better detail.
Yeah, remember slower speed gives you better detail. Well, what does slower speed mean as far as patient exposure? Do we need more or less? More. We need more. Okay, you guys remember your speeds. That's good. Okay, so close collimation, very close collimation. You can see that we use low kVp. This looks great, but everything else is washed out. But I don't care about this. I care about that. This looks great. This is a big nose. It's a honker. Well, you know why it's big, right? Because they fractured the nose. It's swollen. Okay, and then here's another bilateral.
Wait, they shot it on the same, was it film and they shot it on the same
cassette. Oh. So on the same, so we would do, like for instance, here's my left, okay? And then I would, there's my right. So we can actually do 2 images on one cassette. That's the way we used to do it. Okay. But I have an issue with this image. What's my issue? Does it look like they centered over the nasal bone? Looks like they centered somewhere down here. Because now we got the mouth in here too. You can see the soft tissue of the mouth. You can even see teeth. And then look at the collimation. This is all you need, guys, right here. This wasn't a Cypress College student. Done by somebody else. Okay. So mark your films appropriately. If you're doing bilateral, make sure you put a right on a right lateral and a left lateral so the doctor will know which is which. Okay? Okay, what is that pointing to?
Well, it's not palatine bone, no? Maxilla.
Okay, you guys remember the anterior spine of the maxilla?
We need the app.
We need the app. The anterior spine, okay. She said it, I did it. I'm going to pull it up. Aw.
You wanted it.
Oh, what happened? It kicked out.
You overuse it.
Okay, here's the anterior spine. anterior spine of the maxilla. Okay, so this is what we're seeing. That is what we're seeing in this X-ray. Okay, the anterior spine of the maxilla. Okay. And it's supposed to be pointing up. You see it, it's horizontal. I think this individual's face got really bashed in because this should actually be pointing up. And it's pointing this way. So there might be a break here somewhere. Okay, optic foramina. Okay, we already know the P.A. Caldwell, so let's talk about the Reese in the waters. Okay, the Reese I had already introduced you to it. Okay, so first of all, you're going to do your AML. So here's your AML. AML is going to be perpendicular with the image receptor. Okay. Now I'm going to do is I'm going to rotate my head towards the affected side. Okay, so if I'm looking at my right orbit, it's going to be right orbit down closest to the image receptor. So when you do your AML perpendicular with a 37-degree rotation, it should be nose, cheek, chin on the table or your image receptor. Nose, cheek, chin. Okay, so perpendicular to the downside orbit, that is where the central ray is going to be exiting. Now, we do it one at a time. You focus on one orbit, okay? Then you do the other orbit, okay, for comparison. All right. Now, this is something that I added new, because this depends on your facility. You're either just going to collimate to the area of interest, or you're going to collimate to include both orbits. Okay? Either way, you're still going to do bilateral. They still have to be bilateral. So you do one, even with the collimator open, you're still going to do the other with the collimator open. Okay? So it's going to be up to your facility. Are we just collimating to one orbit of effect, or do we include both? So that's the parietal orbital oblique projection, also known as the Reese method. We're going to use the AML, and we're going to use the perpendicular, and then we're going to use the mid-sagittal plane, 53 degrees from the IR, or 37 degrees from the mid-sagittal plane. Okay, and this is why we do it. Here's the AML, perpendicular, and then we do a rotation of 37 degrees to get at that optic foramen. That's not on your slides, I added that too, just for reference when we're talking about this. You guys want me to upload this to your canvas?
Sure.
I think I said I was going to do that last week with the other slides and I didn't, huh?
You didn't have the same as
Huh? What?
Is that the same slide as earlier in the?
Yeah, but I inserted it here so you had a reference when you were
okay.
looking at this projection. Okay. Upright Reese. You know, every time I see, do you guys remember a student? There's a student that looks like this. You may have seen him in some of your pre-reg classes.
What
James,
is?
you know him. What's his name?
I think it's Dave.
No, the guy with the hat.
Oh, Robert.
Robert.
Peterson.
Robert Peterson. You guys know Robert Peterson? I think you had him in your. Okay, never mind.
So is it him?
No, it's not him. But when I see it, he looks just like this guy.
Not quite as old, but
Okay.
I think he's about 50.
Who?
Robert.
He ain't 50.
Then we're talking about different guys.
Oh, okay. All right, so here is a properly positioned Reese, right? So there's your optic foramen. There's your strut. We're going to look at both. So where should the optic foramen be located if the orbit was broken down into quadrants?
Lower outer.
Lower outer. Okay, lower outer. So we're going to practice this in lab. Collimate to the area of interest. I don't want to see forehead. I don't want to see chin. We're going to practice collimating in class, okay? So like this. I don't need to see all this. Okay. So this is where they included both orbits. Okay? But the one of interest is this is the right, this is the left. And the reason why they do this is because if you look over here, on this side you can actually see the outer rim of the opposite orbit a lot better. And that's why they include it. You can really see this bed really good on the opposite orbit. Okay. Are you guys okay with the optic foramen being in the lower outer quadrant? Do you guys see the optic foramen?
Yeah.
Okay, where is it?
In lower outer
This
quadrant.
one?
No.
That one?
No.
That one?
It's in the hallway.
Okay. There you go. Bingo. All right. Zygomatic arches, what's that? Cheekbones. You guys recognize the views already? They're the same views over and over and over and over again. You guys already know the SMV, so here's your SMV. Okay? Submental vertex. The IOML is going to be parallel with the image receptor, so we really need a good sheet extension. We want the top of the head, the vertex, on top of the image receptor. Okay? Make sure there's no rotation to the head. So the mid-sagittal plane should also be perpendicular with the image receptor. Okay? Central ray, 1.5 inch below the mandibular symphysis. So, set up your room first. This should be the last thing you do. Set up your room, position them last. Okay? Don't put them here and then you're fiddling with your x-ray tube. Oh, hold it. Okay. No, just give me a couple more minutes. Don't do that. Okay? Do this last. Okay? And if you're going to sit them down on a chair, make sure the chair doesn't have any wheels, because they will be leaning back. Okay? The trick here is the further that your back is away from the image receptor, it is a lot easier to do this than if you were closer to the image receptor. Now you're really having to slide forward, so it's a lot easier to put it up on the board.
Do you need an X-ray?
Does that make sense? So the further that the bottom is away from the board, it's a lot easier to get them to the top. But the closer they are, it's harder to reach that position. Okay, upright. Okay, so here, oh, and by the way, it is done bilaterally. Okay, I think that's something new. You don't have that on your slide. So it is, this SMV is for bilateral evaluation. Are you guys okay with this technique? Think again. What are we looking at?
It's a very thin
We're
bone.
looking at the jug handles, right? This is what we're concerned with. So this is going to get washed out. This is going to be dense. It's going to be harder to penetrate, but it's perfect for the arches. Okay, it's perfect for the arches. Okay? So zygomatic arches are going to be well demonstrated, symmetrical, no rotation. The mandibular symphysis is going to be superimposed by the frontal bone. So you're not going to see this here. Okay? So 1.5 inches below the mandibular symphysis. All right. I like this. This is good collimation. This one's just too much. This is good collimation. I'm all about collimation, guys. Okay, this is the oblique inferior superior. And this I put up. This is if you're just evaluating one of the arches. Evaluating one of the arches. So the position is the same, in which you have them put their head all the way back with the top of their head on the image receptor. But this is where the challenge is, okay? I need to get a skull.
Go on. Go.
And I was making fun of you earlier too. Yeah, this is perfect. Okay, so SMV. So they're going to be just like this. All right. So two things have to happen. You're going to rotate. If we're looking at this cheekbone, they're going to rotate 15 degrees, and then there's going to be a 15-degree tilt, in which the vertex of the head is, okay, so the top of the head is going to be towards the affected side. So it's going to be a rotation and a tilt. Yeah. Okay, a rotation, tilt. It's 15, 15.
And we're looking at
15.
which one? At the
We're
left
looking
one?
at this one.
Now it looks like it's superimposed with all the other bones.
Well, it's,
Like on the skull right now on your shoulder.
yeah, it does look like that way,
Right.
okay? But it's not. And here's the other catch. Here's the other catch. Okay, so you do like this and like this. Okay? This is superimposed because now it's right over the mandible. This one isn't. And so when you take the shot, it's also tangential, meaning that you're skimming the bone. Okay, it's tangential. So you're skimming the mandibular ramus. The mandibular ramus.
Doesn't that tilt the mandible? This in the way of this?
That's what I was talking about.
Okay, let's do this. Let's go back to I'm going to go to my app now and see how this works. Or can I? Can I?
Can you separate the head from the body?
This might be a while, guys.
Just
Do we have time? No? Wait, where's all my commands? Oh, there they are. Multiple, okay. Okay, so let's hide others. So if we, oh, I'm missing some bones.
Yeah.
Yeah, okay.
The mandible.
Uno momento. Oh, what happened?
You're missing one temporal bone on the right. No, next.
What am I missing?
You're missing the arch itself, the process, the zygomatic
Oh,
process.
yes.
And you had it, then you got rid
Oh,
of
I
it.
did, huh? Okay, so. Okay. So we said 15 degrees. And then, do my tilt.